Welcome everyone to CAPE's National Ground Rounds. It is a beautiful day here in Toronto, and I am thrilled to be joined by people all across Canada as we talk about leading edge sepsis care. First, I'm introduced by my co-host, Samir Sharif, who will be moderating this session with me. Samir is an accomplished emergency and ICU physician at McMaster University, also one of my resident colleagues from not too many years ago, Samir. I'm also thrilled to be joined by a wonderful panel. Kirsten Fiest is an epidemiologist, professor of critical care medicine, and scientific director of the O'Brien Institute for Public Health at the University of Calgary. Jen Greene is an advanced care paramedic and EMS researcher with Dalhousie University Division of EMS in Nova Scotia. And Dr. Melissa Parker is a dual-trained pediatric emergency physician and pediatric critical care physician at McMaster University, where she serves as professor and division head of pediatric critical care. We have a packed agenda, and I want to make sure that we get time for your questions. So the only housekeeping I will mention is that at the very end, there is a quick survey. We would love for your participation in that. Very quickly, our learning objectives are really to cover the continuum of sepsis care today. There's no financial support to disclose. We, as a scientific planning committee, worked our very hardest to mitigate any potential bias. And again, here is our panel for today. Without further ado, Kirsten, take us away.
Thank you very much for the kind introduction and an invitation to be here today to speak to you. I'm coming to you from Treaty 7 territory in Calgary. I'm going to be speaking today about what the public knows about sepsis and the implications for the emergency department. I'll get you to advance the slides, please. I have no conflicts of interest or disclosures. Next slide. I would like to acknowledge, oh, can you go back? Just one, I would like to acknowledge that this work is done as part of Sepsis Canada, which is funded through the Canadian Institutes of Health Research. Okay, 2 slides, Blair, thank you. So why raise awareness about sepsis? Sepsis has an immense global burden, and it's being that it's a medical emergency, knowing the risks and being able to spot the symptoms for the public and either seek medical help or initiate treatment could really save lives. And so the global burden of disease study done by the WHO and really speaks to the magnitude of the issue. 1 in 5 people with sepsis die, and it costs billions of dollars to provide care. And most relevant for this group is that most sepsis cases start in the community. Next slide, please. So I'm sure I don't have to convince you all that sepsis is important, but what about the public and its role and healthcare providers as well, and their role in knowing about sepsis, its risk factors, its symptoms, and what we can do to prevent it. So here's a little timeline of sepsis awareness globally, starting with the Sepsis 1 consensus definitions, followed by Sepsis 2, some surviving sepsis campaigns, and more recently, the Berlin Declaration on Sepsis, which really is the most recent acknowledgement on the progress made in the fight against sepsis and also hoping to reinvigorate global action on sepsis based on the 2017 WHO resolution. Next slide, please. So some of the work that we've been doing through Sepsis Canada has been to understand what patients, the public, and healthcare providers know about sepsis. People need to present to the hospital in order to receive treatment or present to a physician. And so through Sepsis Canada, myself and Gina Parsons-Lee and a number of our colleagues have been working on understanding what do people know about sepsis. Next slide, please. So we started with the scoping review. And I just want to take you through very high level what we found to give you a sense of where patients and families and the public might be coming from, and to contrast that to the knowledge that healthcare professionals had. So we found 80 studies that discussed knowledge of sepsis in terms of risk factors, prevention, access to information, and they were split across the patient, public, and healthcare provider groups. Next slide, please. And to follow a similar a timeline to plot the previous sepsis awareness initiatives that have gone on across the world, you'll note the time is on the x-axis and the proportion of sepsis awareness in different countries is plotted on the Y, going from 0 to 100 with those dashed lines throughout indicating different sepsis awareness campaigns or different initiatives globally. The green circles represent public knowledge, the orange squares patient knowledge, and the blue triangles healthcare provider knowledge. And although, you know, this is very high level, not meant to come to any strong conclusions, there does appear to be a trend towards increasing awareness, at least, of sepsis over time. In terms of specific signs and symptoms of sepsis, there's obviously, not surprisingly, a lot more knowledge of sepsis among healthcare providers. There's not as much information on specific signs and symptoms among patients, but the public does seem to know in lay terms that certain features of sepsis are in fact something that they should seek medical attention for. The most sorry, you're trying to anticipate me, Blair, and I'm not going quite as quickly as you want me to be. So as displayed in this figure, it's clear that fever is a sign and symptom of sepsis that is correctly identified by all groups of people, whereas hypothermia and high heart rate perhaps indicate a bit of a knowledge gap among those groups. Next slide, please. So just to let you know where patients and the public are getting their information on sepsis. When we consider how we can improve awareness on sepsis, it's really important to think about where the different groups are receiving their information. Now, only 10 studies did report on these sources of sepsis, but most reported getting their information from hospital or medical personnel, and some from newspapers, so that's among patients. Among the public, most people either get it through their formal education or from the media and internet. And then not surprisingly, most healthcare professionals receive their information from through their professional continuing education and professional practice or through their formal training. So we reviewed that literature and it gave us a good place to start, but we really wanted to know, what does the average Canadian person actually know and understand about sepsis? Because this will eventually be the beginning of a public campaign to improve sepsis awareness in Canada. So we'll go to the next slide. And we used Ipsos Reid to survey 3,200 Canadians across English and French across the country, stratified sampling to ensure that we had, excuse me, adequate representation from different groups. Of course, I'm sick as I'm here today. And we asked questions about their awareness, knowledge, and where they accessed information on sepsis. So if you go to the next slide, excuse me, 61% of Canadians surveyed had heard about sepsis. They knew what sepsis was. Next slide, please, Blair. Having female sex, older adults, and some college or university education were all factors associated with increased awareness of sepsis. If you go to the next slide, please. When it comes to sepsis knowledge, 53% of the public were able to correctly identify definitions of sepsis. 32% were correctly able to identify symptoms of sepsis. 17% were able to understand known sepsis risk factors, and 36% understood different preventative strategies. Not kind of surprisingly, we did find that very few people understood that immunization against influenza and COVID were effective preventative strategies for sepsis. Now, those factors that are associated with increased knowledge were female sex, being an older adult, having some college or university education, previous exposure to sepsis, and if they had been working in healthcare. And then in terms of where people are accessing their information, similar to our systematic review, we found that the majority of people were accessing information related to sepsis from the media or different TV and news sources. However, they wanted to receive that information from healthcare providers. So there was a discordance between where they were receiving the information and where they really wished that they could get more information about sepsis. So if you go to the next slide, let's talk about what are the implications for public expectations of sepsis care in the emergency department. So direct research on this is pretty limited. The research that we'd been doing before was even more broad. It was focused on sepsis more generally, but a lot of specific work to the ED is limited, and most of the evidence does rely on some general ED patient and family perception studies, so not specific to sepsis. And the evidence is mostly descriptive with limited quantitative data. However, if you go to the next slide, there are a few studies out there. The references can be found at the bottom, and their expectations for sepsis care in the emergency department really don't differ that much from probably their expectations of care in general. So sepsis is obviously difficult to diagnose in the emergency department, especially given its non-specific symptoms. And so a role that the emergency room team could play is in terms of raising awareness of sepsis, given that public awareness is generally pretty low. Using the word sepsis is really important. So we've done some interviews with people across the country, and they had never even heard the word sepsis until they'd requested copies of their medical chart or spoken with their family doctor. So using the word sepsis and being really clear is critical. And then in terms of people with sepsis often present to the emergency department as their first point of contact. So timely identification of sepsis is really important to improve patient outcomes and reduce mortality. And so a lot of the studies that are out there have focused on improving sepsis recognition in the emergency department, beginning treatment early and therefore improving patient outcomes. And patient and families really do expect immediate attention for patients with severe illness, and sepsis is a severe illness. And so just when sepsis is suspected, thinking sepsis and treating sepsis early is critical. In terms of involvement in care, so any emergency department care practices that can foster family presence and participation in care will likely improve the patient and family experience. And in some work that we've done in delirium, where we partner with patients and families to identify, prevent, and manage delirium, they're often the best source of information. And so family can provide contextual details that can help with a sepsis diagnosis. And finally, pain management. So pain isn't specifically mentioned in the surviving sepsis guidelines, but across all of the articles that I quickly reviewed talking about sepsis care in the emergency department, at least in the adult population, pain is a common symptom for people. And so appropriate pain management can also be associated with improvements in patient satisfaction and care. And that's something that patients may know, they may think they know is a sign or symptom of sepsis. So that was a very quick overview of the work we've done to date on what the public knows about sepsis, very little, about what they know about risk factors and outcomes. And I think probably the biggest takeaway would be using the word sepsis and using any touch points with patients and family members as an opportunity to provide education. Thank you.
Thank you so much, Kirsten. It wasn't so long ago, last month I was on ICU service. I used the word sepsis, and the family member I was speaking to just started wailing and crying in tears. So she had heard of it, but it's interesting to know how the public is perceiving that word and sort of the clinical entity as well. So given that the public often first comes into contact with healthcare through 911, we're going to move over to Jen Greene to hear about what's happening in the streets as paramedics try to also identify sepsis.
Thank you so much. Yeah, so kind of the next stage here. So I'll tell you what's going on in the streets, as Blair says. So I have no conflicts of interest to declare. However, I will be also reporting some results from a study that was funded by Sepsis Canada. Okay. So I'm here today not only to bring the pre-hospital paramedic perspective, but also to share some of the findings of a major project that I had the privilege to lead a scoping review for Sepsis Canada, alongside Dr. Carter and Dr. Bigham, who are both on the line here today. This review, the largest to date, explored barriers, facilitators, and strategies to shape sepsis care in the emergency department and pre-hospital environment. Our work will soon be published in the Canadian Journal of Emergency Medicine, and I'm thrilled to be able to be here today to share with you some more of the more granular behind the scenes insights that we weren't able to fit into the manuscript. So today I'll focus it on what's happening before the patients arrive at the emergency department, how paramedics are detecting, treating, and alerting teams about sepsis in the field. Next slide, please. Oh, nope, we're on the right one. So paramedics are often the first point of medical contact for patients with sepsis. It's estimated that 3 out of the 4 ED patients diagnosed with sepsis will arrive with paramedics. And of those patients, you can imagine they do tend to be sicker. This means that they may be the patients who could benefit most from early recognition and intervention. And so I think that there's tremendous opportunity here. Next slide, please. So let's talk about recognition, because this is where most of the challenge lies. Our scoping review found that difficulty recognizing sepsis was the most common barrier reported, appearing in about 45% of the studies that we examined. Interestingly, that challenge was shared equally between the pre-hospital and ED environments. So if both sides are struggling with recognition, where do we start improving? Unsurprisingly, the top strategy identified across the literature was the development of unique screening tools and structured approaches for identifying sepsis. From the pre-hospital lens, our goal is to screen with high sensitivity to capture as many sepsis patients as possible. And much of the foundational work in this space comes from Dr. Daniel Lane's team, whose research has really shaped how we think about pre-hospital sepsis identification. Next slide, please. So what are paramedics actually using to identify sepsis in the field? Many rely on vital sign-based tools. A common strategy is a modified SIRS criteria, similar to what's used in hospital, but without the white count. In a systematic review by Lane and colleagues in 2015, this structured approach showed a moderate sensitivity. More recently, in 2020, another report compared a few others, including the CIP score, Critical Illness Prediction score, the NEWS score, and QSOFA. They found that QSOFA might be the most practical for paramedics, with a sensitivity of 0.4 and a positive predictive value of 0.66. So we're getting closer, but there's still room to improve. One intriguing area for potential improvement is at the 911 dispatch stage. So in a review, again by Lane et al., about 62% of patients later diagnosed with sepsis were initially dispatched under the dispatch categories of breathing problems, sick patient, or interfacility transfer. And then once paramedics were on scene with these patients, the most common chief complaint reported amongst these patients were shortness of breath, altered mental status, or decreased level of consciousness. And so we can kind of see that there's pretty vague complaints here, and this is part of what makes it so hard. Next slide, please, Blair. So can we do better? If the vital sign tools are imperfect, what can we do to make them more sensitive? And can we find something more objective, maybe a biomarker? There's growing interest in point-of-care lactate. One recent systematic review found mixed evidence on whether pre-hospital lactate reliably predicted sepsis, but studies out of Sweden showed more promising results. Lactate had a specificity of 95.9%, and paramedics, when using a threshold of over 3 millimoles per liter, found an improved sepsis identification. So, adding a simple objective marker like this could help strengthen our clinical suspicion and help us communicate that suspicion more effectively to ED staff. Next slide, please. And that brings us to one of our biggest themes. In our review, we found communication, specifically handover communication challenges between the pre-hospital and ED teams, was a major barrier. Professional cultural differences, professional silos, and frankly, a lack of mutual understanding can all get in the way. But when paramedics can quantify what they're seeing with objective data like positive biomarkers or structured screening tools, that does help add credibility. And it's about building a shared language between the professions. Next slide, please. Perhaps one of the most promising solutions are system-level alerts. We've already seen the power of pre-hospital alerts for STEMI and stroke, where early recognition by paramedics combined with rapid ED activation can dramatically improve outcomes. Those systems work because they're multidisciplinary, they're protocol-driven, they systematize the expected communication, and indicate a predetermined response to that alert. And while the evidence base for pre-hospital sepsis alerts is still emerging, there's already moderate quality studies showing improvements in time to sepsis core measures, time to antibiotics, and any more antibiotics within the recommended 60 minutes. Next slide, please. So since we're speaking about antibiotics, we know that antibiotic time matters. It matters a lot. And when we also know that paramedics have a moderate ability to recognize sepsis in the field. So then we would naturally ask, why aren't more paramedics employed to initiate antibiotics in the field? And this is a growing body of evidence exploring the question. Several studies, mostly moderate in quality, suggest that pre-hospital antibiotic administration is feasible and may even reduce mortality. However, when we look at the larger randomized trials, the picture becomes less clear. Those studies haven't yet shown a statistically significant difference in mortality outcomes. So right now, we can say that it's promising but not definitive. We simply don't yet have the high quality evidence to prove a survival benefit. With that said, many of us are watching really closely to see the results of the pit stop trial out of Ontario, which is expected to add some much needed clarity to this question. Next slide, please. So moving forward, where do we go from here? We have to keep persevering on this very important topic, asking great questions and publishing what we're doing locally. If you're looking to keep your EMS service up to date, I'd encourage you to visit the Pre-Hospital Evidence-Based Practice Program, or PEP. It's a free online living repository of current research on EMS interventions, including antibiotics and biomarkers for sepsis. And it's a fantastic resource for building protocols or QI initiatives. And in closing, paramedics are not just transporters. We are clinicians uniquely positioned to recognize sepsis really early, initiate time-critical interventions, and set the tone for what happens in the emergency department. Thank you all for the opportunity to share, and I'll look forward to any questions you may have.
Awesome. Thank you so much, Jen. As a former paramedic, I'm so proud to see paramedic scientists contributing to their own practice, and it's a pleasure to have you here. So from the public to the streets and now into the emergency department, I will hand it over to Alix Carter.
Thanks, Blair. And thanks everyone for the opportunity to share a little bit more of our work here today. This work also was funded through Sepsis Canada, which is a CIHR funded network. And go to the next slide. So our goal with care in the emergency department, like in the pre-hospital environment, is earlier identification, initiation of early goal-directed therapy, thinking back to that seminal Rivers paper around EGDT. We're looking here really talking about a good, sensitive, and specific screening tool, early initiation of volume support through fluids and pressors where necessary, and getting those antibiotics on board. So we know that the guidelines have been saying that. They've been saying that for a decade, and somehow it's just not catching on. And there have been a few papers that have looked at both the Surviving Sepsis campaign and the CAPE sepsis guidelines, and we're still struggling. So our work tried to figure out why we haven't been able to crack this nut. You've heard a bit about the scoping review already, and Jen very nicely focused on the EMS or paramedic practice aspect of those, but many of the papers that we found were also in the emergency department setting. Now, I will caution that many of those were in the tertiary care urban emergency department setting, which I think is really important for us to think about in a country like Canada. Many of those, as Jen mentioned, did focus on increasing knowledge and on knowledge gaps around the sepsis guidelines, and also on using education bundles as well as visual reminders and screening checklists. So to that, we also added a pan-Canadian survey, which about half of the respondents to the survey did work in the emergency department setting, and about a third of them did work in a rural center, which is, I think, a very valuable addition to the literature that's out there. And we interviewed paramedics, physicians, and nurses as well in more depth to explore the responses that we were getting to the survey. So we went with triangulation of all of those responses, and we're able to come up with, hopefully, a few approaches that we can take to finally get a bit closer to that timely sepsis care in the ED. Next slide. The first thing we asked is, what's getting in the way? Why aren't we doing it? And like you've already probably gathered, we got a strong message back, again, in these approaches, that triage is really important. Under triage, for sure, under recognition, but we're also hearing from the front line that over triage is a bit of a concern, and that may be one of the barriers to individuals taking up the surviving sepsis directives as written, which would call for very early antibiotics before a lot of lab work is back. So people are concerned about antimicrobial stewardship and the potential collateral damage from that. People are also concerned that in an emergency department where so many things are pulling our attention and need rapid pathways and are time sensitive, that it's a zero-sum game, and that focusing too much on one condition like sepsis could actually have unintended consequences in another area. And these are important considerations for us as we operationalize the guidelines. We also heard a lot about alert fatigue. And again, this comes back to having a tool for triage that is both sensitive and specific, so that we're not picking up a lot of people who end up not having sepsis ultimately, who are then getting antibiotics that they never needed, but also burning out the staff in the emergency department who don't want to pay attention to a flag that ends up meaning nothing. And so, again, more sensitive and specific triage. We've heard that before, definitely coming through loud and clear. We also compared across the professions, and it was one of the places that the responses were most different was this question around the agreement with the statement, "I trust the evidence behind the Surviving Sepsis campaign." And physicians were by far the lowest in agreement with that statement. And that the issue came down to some of the aspects of the bundle, and so the whole bundle got thrown out with the bathwater. So these may be important things for the next iteration of the Surviving Sepsis campaign to think about as well. And then finally, although most popular in the strategies published in the literature was education and education sessions, the respondents actually came back and said, please, no more training sessions. I can't sit through another day about sepsis. Give me a 15-minute podcast. Give me something I can listen to on my commute home. Give me a PDF or an infographic, but don't make me sit through another day-long session on sepsis. So I think these are really important starting points for us to consider. Next slide, please. I think another really important reminder that we learned from this work is the importance of talking to the front line, because just looking at what's in the literature would miss out on a couple of really important things that the frontline staff told us. So the top barriers that the frontline staff came back with were bed availability or offload delay or access block, and recognition by the public. Also discussion around resources, specifically how long it took to get labs back, but also the resource of experienced human resources, experienced nurses, and the availability of services in a rural environment. They talked about the inability to start treatment in the pre-hospital environment or with paramedics in offload delay and the longer contact times paramedics are having with patients, and timely initiation of ED treatment. Recognition by physicians or by healthcare providers that triage did come up, but it was lower down the list. It certainly wasn't number one. And then that issue of clear and timely communication, RN and paramedic at triage, and also RN and physician when the nurse comes to the physician and says, I'm worried about this person, I think they have sepsis. And if you can click again, it will show where those things actually showed up in the scoping review kind of rank list. And that recognition by the public wasn't really on the list at all. And that bed availability or access block was much lower on the list. So I think that gathering some insights from the front line this may really highlight the importance of doing that as we try to craft our next attempt at coming closer to timely sepsis care in the ED. Next slide, please. So diving a little deeper into those blocks, access block. Everyone on this call, I'm sure, would love to see the day that we solve access block. I will hope and pray for that miracle. But until then, we have to find a way to still deliver this care in an access block environment. And so strategies like, well, let's make them all a CTAS 2. Sepsis should be a CTAS 2. Our respondents told us that that's great, but they'll sit in the hall with all the other CTAS 2s and wait until they crash. There's an element of moral injury related to access block, well beyond sepsis, but relating specifically to what people told us, that this nurse still thinks of a lady who waited 4 hours in the waiting room, and by the time she got into a bed, they had to do a lot of work to catch up. I always think about her. I don't know if she's dead or alive. And so this really sticks with people, the impact that this is having. And that the biggest decision is not just to give antibiotics, it's actually to find a place to see the patient. The second one, as you've heard from Kirsten and her team, is that recognition by the lay public is hugely important. And this can be on either side, that people are coming too soon and making us sort of feel jaded about everyone who comes in thinking they have a terrible infection, or people are coming too late and they're terribly sick and don't realize how sick they are. And wouldn't it be great if we could come up with a simple algorithm like the fast stroke screen that we teach the public, that if you have this, you should call 911. But with sepsis, what is this? And that's the hard part. And also how surprised the public can be sometimes. We would look at, a patient who has chills and a fever and altered mental status, and we would think there's a good chance they have sepsis. But her partner was clearly surprised when I said she had an infection. And so public education and Kirsten's work will be tremendously important. Next slide, please. The next one that people talked about a lot was resources, the availability of timely lab work, the availability of senior nurses who have the experience and can come to the doc and say, I'm really worried about this person. And also having guidelines that are not meant for rural situations. The guidelines say put in a central line. They say, what's your central venous pressure, and titrate your fluid resuscitation. And the response to that was, that's great, but none of my nurses have ever done a central line, and I'm running the entire department on my own. And so our Canadian guidelines need to reflect the rural reality. One of the things that also came out loud and clear, and you've heard from Jen about leveraging the scope of practice and enabling paramedics to work at top of scope. Certainly also the idea that nurses at triage could be working at top of scope. So paramedic contact times are not half an hour anymore. They could be 6 hours, 8 hours, and we could really be gaining time in ways that older literature about paramedic antibiotic initiation just doesn't apply to our present reality. And that a directive at triage, some sort of alert, a sepsis alert that prompts a cascade of events that don't rely on getting placed in a bed and being seen by a physician, could certainly allow us to function better in this access block environment. Recognition by healthcare is still tricky. It is not an easy thing to diagnose and recognize. Not everyone fits the mold. Not everyone read the textbook and walks in with tachycardia and hypotension and a fever and is obvious. And so that can be one of the case finding can be one of the hardest parts. And that solutions to that could include a better identification and triage, sensitive and specific, maybe visual cues, infographics, computer-based triage, and potentially the use of AI as well. And the sixth one, again, around that communication, that if the communication is not using common language, or it's not being received in a way that acts upon the information, or if we're not allowing a system that gives the recipient of the information any action that can be taken, then our communication is broken. And it's tremendously important. And that's nurse paramedic, and it's nurse physician, and it's between physicians as well. I did talk about the importance of the rural environment and addressing that in our sepsis guidelines and in our practice. We did do a breakdown of our rural and urban responses for the most part, actually quite similar, which is good in terms of having a national guideline within 5 percentage points of each other. There are two that I would highlight. One is that access block or bed availability, which is no surprise, I think, higher in the urban setting, although not low. 60% still said in the rural setting that this is an extreme or moderate barrier. And then on the flip side, the availability of definitive treatment was much more of a barrier for people working in the rural centers. And so that may be something that we need to address as well. And finally, to sum that up and think about how we're going to move forward and provide more timely care in the emergency department, it really requires a system-level commitment to change, focusing around things like public awareness, a more sensitive and specific sepsis alert, which may incorporate the use of technology, using common language and improving our communication, enabling practitioners to work at the top of their scope, and having integrated care pathways that incorporate the system of care.
Thank you so much, Alix. We're going to take a pause on our continuum of sepsis care. Although Melissa works in an ICU, we're not going to go up the elevator into the ICU. We're going to take a pause to reflect on, across all locations, how can we best identify and get a jump start on sepsis for our most vulnerable? Melissa, take us away with the pediatric pearls.
Thanks, Blair. And, you know, there's some advantages to going last in a panel of talks, because I really love that Alix and Jen and Kirsten have set me up nicely for some of the things that I'm going to cover. Next slide. These are my disclosures here. We were asked to disclose any grants held, even though my grant funding is from CIHR, which is a government agency, and from McMaster, which is a nonprofit university. I'm also listed on the World Sepsis Day website as an ambassador, and you'll see a quote from me there around finding sepsis early, which hopefully you will all agree is something we can all aspire to do. So though I no longer work in the emergency department clinically, I hope that you guys can all appreciate that this is how it feels. I know this is how it feels, not only in the emerge, but in the pre-hospital environment and in the ICU as well, but in particular in the emergency department, where your whole emerge is a haystack, quite frankly. You know, you're looking for the PE needle, you're looking for the sepsis needle, and of course, most of us have to attend M&M rounds where your friendly administrator or a QI expert is neatly presenting the timeline and all of the data that you didn't have when you first met the patient. So this is really hard to do. And I think, as we've seen from the timeline that Kirsten presented, you know, it's been decades really that we've been trying to improve on some of the tools that we use to identify sepsis early. Next slide. So what makes diagnosing sepsis in kids so hard? So systemic inflammatory response syndrome is, you know, we still talk about SIRS, but it really is no longer used in the diagnosis of sepsis. That's in part because we know it's specific, but it's not sensitive. It doesn't identify, you know, our patients who are immunosuppressed, who don't necessarily have the ability to mount a fever. And we've already heard about, you know, sepsis flags everywhere that, you know, if we over-identify, it's really hard to titrate the energy where it belongs. The other challenge, and I was noting that Alix also talked about the CTAS2 patients, is that, you know, kids with fever and viral infections frequently have deranged vital signs. And so you wind up with an ED full of CTAS2 patients who aren't seen within 15 minutes. And frankly, many of them who are treated with Advil or Tylenol or acetaminophen or ibuprofen, you know, their vital signs will normalize and these children are ultimately discharged. The challenge is that a small proportion of those kids actually do have sepsis or early septic shock, and it's trying to pick the needle out of the haystack. Of course, by the time kids are actually manifesting fulminant signs of septic shock, the challenge is no longer diagnosis, but one that that moves to management. What are some of the current tools that are actually being used to identify kids with sepsis early? Well, now the latest kid on the block is the Phoenix Sepsis Score, which some of you may be familiar with. That was published in 2024. It was developed based on machine learning and over 1 million patients where they applied this to. But the score actually has some of the similar hallmarks of previous criteria, going all the way back to the Goldstein criteria, where it's really a combination of vital signs and organ status, plus laboratory values, which again aren't necessarily available at the time that you initially see the patient. So what are we left with? History is 90% of diagnosis. That's really important, especially listening to parents. What are the patient-specific risk factors? I already spoke about patients who are immunosuppressed, or patients that have been on steroids, even for things like asthma. And then you're going to look at your vital signs and your clinical exam findings. And it's important that we don't ignore vital signs. We need to pay attention to them when they're 2 standard deviations outside of the normal reference range. But in children, you also have the challenge of examining a screaming infant and trying to interpret whether that heart rate is due to agitation or whether that's actually a marker of sepsis. There are certain clinical exam findings, which we're going to get to in a minute, that can be subtle clues of a child who is very unwell. And so really just, taking the time to look a child over carefully, even in a parent's arms, can give you some of those early signals. Mental status is one that for me has been always quite reliable. And I'll always remember meeting an adolescent patient who was playing on his Xbox and in mid-conversation would actually just nod off to sleep. And I would wake him back up, and then he would nod back off to sleep. He ultimately wound up having Klebsiella sepsis and didn't actually mount a fever or hypotension until actually after we had already cultured him and started antibiotics. So mental status can be one of the earliest signs of sepsis, and that's important to remember. Laboratory investigations, helpful when we get them, but usually don't have them for at least an hour until after you've seen the patient. So typically these wind up being more helpful for risk stratification or confirmation of your diagnosis. Next slide. Grunting. Some of you may have seen grunting before, but this is actually a really interesting physical finding and one that can be really subtle. So I think Blair's going to just try and play a couple videos here to show what that is. And just while he's pulling up the other video, I mean, one of the reasons I thought I'd share this with you is because grunting is often described or even mistaken by clinicians as crying. It's not crying, it's grunting, but it can sound like crying. And actually, I recently met a patient who had some very subtle signs of grunting, and the eMERGE docs had actually already, based on altered mental status, the history of presentation, been concerned enough about this infant to do a full septic workup and start the kid on antibiotics. And by the time I met them, again, the signs were quite simple: grunting, tachypnea, and the patient actually wound up having gram-negative sepsis. And had that not been recognized early, it would have had a very different outcome. Next slide. So what about patient and system level differences? As we all, there's additional challenges with children. Vital sign norms and presenting features can vary by age. Grunting tends to be something specific to, very young children. Certain infectious syndromes like bronchiolitis can actually meet the criteria of infection plus organ dysfunction. But if you actually ask any pediatrician, they wouldn't really consider bronchiolitis to be sepsis. Community hospital staff comfort with pediatric procedures, ones that are fairly basic, things like blood work, IV access, and urinary catheterization. many years ago, and when working as a consulting pediatrician, I often would actually have to do the urinary catheterization in neonates and infants myself, because the nurses weren't necessarily skilled in that, even within an urban center. And then finally, definitive care may actually require transport to a tertiary care center to receive appropriate care. We often take for granted that in community hospitals, you often have an adult intensivist available who can help you with your sickest adult patients, whereas not all community hospitals necessarily even have a pediatrician on call, let alone one who's comfortable managing a child with septic shock. So this adds additional layers of complexity to caring for these patients. Next slide. I think that's it for me. Thanks, Blair.
That's great. Thank you so much, Melissa. Thanks, Blair, for leading us through this wonderful journey from, starting at outside the hospital, coming into the emergency department. So we have a few questions in the chat, and I know Blair and I had some questions of our own. So Melissa, since you were the last one to go, I did have a question for you, more for healthcare providers, about recognizing that subset of patients who come in with sepsis, and we've all seen this. And then, perhaps they get intubated and they get worse. So it's like and it's not the act of intubation alone that gets them worse. They're like group A strep sepsis. They're in that little train going downhill really fast, really quickly. How do you recognize that patient? Because as we all know, if you take those measures beforehand, you maximize your chances of success. So are there some pearls? And I know it's not necessarily rooted in evidence, it's maybe things that you see. What makes you worried to say, hey, this kid is not going to do well. We need to have all hands on deck before we even get started on resuscitating them properly?
There's a lot in there.
Sorry.
And I'll try and do my best to answer what I think you're asking. I mean, the physiology of cardiopulmonary interactions is not unique to children. There's deleterious effects from the sedative medications you give for RSI in adults as well as children. Same for positive pressure ventilation. You layer that on top, you're going to impact your venous return and your cardiac output. So I think in terms of the timing of things like intubation, the challenges around that are not unique to children. And really, a lot of it winds up being a judgment call in terms of how much resuscitation you do prior to making a decision to proceed to intubation, because you'll know when it's too late. But if you do it too early, then it's not going to be well tolerated. Maybe one of the clinical pearls that I'll share that I actually learned myself as a trainee, and I actually like to use is and I have the benefit of working in an academic center, so I have helpers around at various stages. But I'll take the scaredest person in the room, who is usually the most junior trainee, and they will be my human arterial line if I don't have one. And you take that person and they have their hand on the patient's pulse, whether that's a radial or femoral. And so actually that way, when you're giving sedative medications, for example, for intubation and proceeding with intubation, that's the person who's going to tell you the pulse is getting thready, and that's going to be your signal to give. We usually have some 1 in 100,000 epinephrine on hand in a syringe, what we like to call an epi-spritzer. There's other names for it, but so you can actually support an unstable patient through intubation, and often they won't be as unstable as you will make them when you induce them. So you need to anticipate that. And so that's maybe one pearl I'll share is my human arterial line. I don't know if anybody else uses that technique, but it's a great way to get real-time physiologic feedback on what's going on with your patient.
That was great, Melissa. No, that is exactly what I was going for, because I think takes a level of expertise and experience to know when to pull the trigger and how to prepare beforehand to do it. And certainly not unique to kids, but the stakes always seem so higher for us who mostly see adults all the time. Kirsten, I had a question for you about public perception of sepsis. What I found captured the mind of the public was when there were a number of articles about group A strep, unfortunately resulting in fatalities in particularly young children. There's a bunch of articles on it, and when I would see parents in the emerge, or even some young adults, they'd be like, "Oh my gosh, do you think I have group A strep?" It was all top of mind. So just wondering what your thoughts were around the public perception about that, and if you think that medium could be harnessed for other things around sepsis.
Absolutely. Thank you. I think part of the disconnect is that people understand the infection and they don't understand that infection can lead to sepsis. So I think, I think there's some education for the public that needs to happen there, that, that infection can lead to sepsis and when they need to seek attention. I do think we need to capitalize when sepsis is in the news, whether it's through unfortunate outbreaks of certain infections, or whether when a celebrity, I think Madonna alluded to having sepsis. And so, when there's a high profile case, whether it's multiple cases or an individual, like part of our public awareness campaign should be using those as teaching opportunities. And I do think, the more, you tug on people's heartstrings, it does seem to resonate more. And so I think we need to any sort of education campaigns and things that happen, really need to we need to have things at the ready so that when things happen, we can get things out. Oh, and I see Saad put something in the chat that kind of alludes to that as well. Thanks, Samir.
No, that's great, Kirsten. Then I guess the next question that was in the chat, maybe both for Alix and Jen. And Jen, I have another question for you related to this one. I know, Alix, you had mentioned about some of the physician perceptions about what are the pros and cons of doing some of these interventions early on that Jen had also talked about. So I think Mary had asked, for pre-hospital antibiotics, what are some thoughts about not being able to culture these patients prior to giving antibiotics? Is that just one of the realities that we accept in an effort to try to improve mortality as best as we can? So just the thoughts on that would be great.
I can take that. Yeah, absolutely. That is, part of that question. Should we be able to get cultures before? And we should. I think that's probably the best practice. There have been studies out there that show that pre-hospital blood culture collection is feasible, and it is reliable. It is within the paramedic scope of practice to perform phlebotomy. I know I worked in an emergency department as well as the pre-hospital setting where I collect blood samples as well as culture. So I think that if you want to have a EMS service that is providing pre-hospital antibiotics, having that as part of this procedure would add to the robustness of that intervention.
That's great. Alix, along those lines, as an emerge doc, we see the CTAS 1s, 2s, 3s, and 4s. I think we all know everyone sees CTAS 1s when they're supposed to be seen. But when it comes to the next few levels, it's kind of a hodgepodge of you do the best that you can. So, I mean, should there be a CTAS 1.5 or like how do we, I know there's been a lot of calls for eliminating the system altogether, but just wondering what your thoughts are about how do we actually, because I mean, it's like an alert system on an Epic EMR. It's like it just keeps giving you flashes. Eventually you're going to be like, okay, I get it. You kind of ignore the problem, but just wondering your thoughts on how we can, as a society, navigate that, if at all.
Yeah, I think you're right. I mean, the CTAS 1s we try to see right away, and everybody else, like our participant said, it waits with all the other CTAS 2s in the hallway, and we don't see them in 15 minutes, no matter what the guidelines say. If there's anything that I could say from what we've learned, it would be a more sensitive and specific triage tool to let us know that this is really a time sensitive. Like we know that that MI really needs to go to the cath lab because time is muscle. That stroke really needs to go up and either get their EVT or get their lytic, because this will change things. Sooner antibiotics will change morbidity and mortality, whereas perhaps there are other things that could wait. And maybe that, I don't know if that makes it a 2A or what, or if it just that we had an alert, a triage screening tool that would be good enough to tell us these are the ones. And we've done it for STEMI and we've done it for stroke with reasonable success. And I think the other part of that is in our access block reality is leveraging those other components of the system, that waiting to see a physician may not need to be the rate limiting step. And there may be ways to do this using our very skilled interprofessional teams that can get things started a bit sooner. I would say that would be if I could learn anything from that work that we've done, those would be the two things I would try first.
I think, no, it's such a great answer for a terrible reality that we have. I mean, Jen, you can comment on this better than most. And Blair, with your past as a paramedic, like on average, in your experience, how often are you waiting in an offload situation in the emerge? And then when you could be out there seeing other patients or doing stuff to actually help them while they're just waiting for bed placement?
I mean, it seems funny. Jen and I both know, you know, in the back hallway or whatever it's affectionately called at any hospital, there can be 8 stretchers, 16 paramedics. That might be more paramedics than there are nurses in the ER that day. And we're literally taking turns drinking coffee and reading our novels. It's a huge waste of resources. Engaging paramedics in offload delay in hospital care, I think, is a no-brainer from a hospital perspective. But the EMS leaders hate that idea because they think the hospitals will like it and get used to it. And paramedics are meant to be out on the street, keeping response times low, not only for septic patients, but for people who get hit by buses and who have STEMIs and cardiac arrests and everything else. It's a tricky resource question. At the end of the day, solving access block is the answer. But of course, we've all said that for 40 years now.
Yeah, those are excellent points, Blair. And you know, like you say, this is the reality, and kind of separating the idea of like of the patient that I have in front of me and the larger issue globally about access block and blocking there. I've always said, you know, I'd rather not be waiting. I'd rather be out in the community, but I have a patient in front of me, and what can I be doing in this moment to care for them the best? And if I have to wait 3, 4, 5, 6 hours, so be it. Employ me to do something during that time. And this idea was part of what inspired one of the questions within my master's thesis, which was, you know, how much earlier could paramedics be identifying and providing some definitive treatment to sepsis patients? And it's hours is what it turns out to be. It's hours. So we can do something better here.
I just wanted to
say one other,
go ahead.
sorry. One other quick thing is not just about antibiotics either, because that one seems to get everybody's back up a lot about, oh, we didn't get a culture, and what if we're wrong and we're giving, you know, Pip-Tazo to everybody, and now we're going to have resistance to Pip-Tazo, and what will we do if we can't use Pip-Tazo anymore? So one of the other things that some of the medics in our survey highlighted was that their guidelines will often say that they can't give fluid until the pressure drops below 90. But our early goal directed therapy would talk about supporting central venous pressures and systemic circulation long before the patient is quite that hypotensive. And so there may be opportunities for other pieces of early therapy that aren't just about antibiotics. I don't want to get too fixated on that one thing that seems to get everybody a little bit uncomfortable. So.
Before I ask the final question, I just want to let people know that they'll get an email with a link to a survey right after rounds. Please, please, please do fill it out. It'll only take a moment, and it will enable you to access your certificate of attendance for your maintenance of certification. And of course, if you know someone who might be interested in this recording, they can access it tomorrow through the CAPE Learning Management System. For the last question, I just want to ask everyone, we talk a lot about delayed recognition and things like that. But sometimes there's no delay. Sometimes we know that someone is septic, but their etiology requires surgical source control. And I would bet that most of the people watching today have been to an M&M on neck fash. And so Samir, Melissa, Jen, Alix, you all work in different systems and hospitals than I do. Has anyone seen a system that gets a patient with neck fash or necrotizing myositis into an operating room faster?
If the time of day is daytime, then yes.
Yeah.
It depends what's going on, Blair. I mean, usually plastics wants an MRI. So it's, yeah, for certain source control, you know, they'll go straight to the OR, but, you know, especially when you're talking like how much tissue are they going to debride, you know, in an infant. I don't know that I've seen anyone go without advanced imaging. I've seen, you know, tissue taken in the ICU to confirm diagnosis. But it's a tricky one. How much do you debride, right? It's kind of, And I'm not a surgeon.
Alix, any final thought?
Yeah, I would have to say this is one where if that's our suspicion, I press pretty hard for the staff to come down, and they'll often do a bedside IND to at least see if that dishwater comes, and that'll when it's been a suspicion, I think the staff have been pretty responsive because they know maybe more than the junior resident off service kind of knows.
A direct to staff phone call. Yeah, I
Yeah.
like that idea. It is the top of the hour, 3 o'clock here in Toronto. I want to thank Samir, my co-host, along with our incredible panel, Melissa, Jen, Alix, Kirsten. Thank you so very much. And Danielle from Cape for being our IT support and whip to make sure that we all showed up on time. Thank you to all of you for showing up. And again, please do fill out your survey so you can get your certificate. Have a wonderful day.